Good evening, everybody. Giridhar sir. Giridhar sir, have you joined? Giridhar sir, are you there? So, good evening, everybody. We welcome you for today's NOEL session. Today, we are going to have case presentation with a theme to cover a short case, which will be there in your exams. And it's very important to understand a growing preterm. Today, we are going to discuss about developmental supportive care and preparation of a high-risk newborn. So for today's session, I have the privilege to introduce the experts. So I am Dr. Abhishek, working at OM Hospital, part of the NOEL committee. I also welcome our other committee members, Akash, Binesh sir, and others. I am not able to find Giridhar sir. I think sir should join soon. So today's experts are Dr. Ashwini RC. Madam is professor at JJ Medical College, Davangere. She did her DM neonatology from prestigious PGI Chandigarh. We welcome you, madam.
Thank you, sir. Thank you.
And our second expert is my own colleague, Dr. Arpita Rai Ghatak. She has done DM neonatology from another prestigious institute of the country, CMC Vellore. So she currently works at OVM Hospital along with me. Welcome you, Arpita.
Good evening. Good evening, everybody. Good evening.
So today's case presentation will be in a PowerPoint format. So I request the experts, they can pause the presentation, ask questions in between. And over to you, Sankirtana. Sankirtana is our fellow who has joined a month back. So over to you, Sankirtana. I know it's a first case presentation. A lot of questions will be there amongst the newcomers and the people who have been doing fellowship for the last 6 months. Over to you, Sankirtana. You can make full screen and start the presentation.
Yes. Good evening, everyone. So I'll be presenting the case today. My baby is baby of M, 31 weeks plus 3 days. Birth weight is 1.96 kg, male baby, appropriate for gestational age, and born on 27th April at 10:25 p.m. Via LSCS. Baby is an early preterm, low birth weight baby with respiratory distress syndrome, apnea of prematurity, suspected early onset sepsis, feed intolerance, hypocalcemia, and neonatal jaundice. Currently, my baby is 34 weeks and in NICU for preterm care. So coming to antenatal history, 33-year-old primary mother, she conceived via IVF and she was booked at a private nursing home nearby, and she had taken prenatal folic acid supplements. First trimester, she had no history of fever, rash or bleeding PV. Second and third trimesters, she received 2 doses of tetanus and she's taken calcium and iron supplements as well. She had history of hypothyroidism, which was diagnosed antenatally, and she is on Thyronorm 150 micrograms for hypothyroidism. She had no history of gestational diabetes or pregnancy-induced hypertension. History of fever at 28 weeks, for which she was admitted for 3 days to the hospital. Her anomaly scan was normal, and last scan was done on the day of delivery, which corresponds to 32 weeks gestation. Liquor was adequate, and estimated fetal weight was 2.05 kg. Mother's blood group was B positive, and her serology workup was negative. Perinatal history. She had PPROM for 24 hours. There were no signs of clinical chorioamnionitis. She received antibiotics and 2 doses of betamethasone, and last dose was given 2 hours prior to delivery. She did not receive magnesium sulfate, and NST was normal.
Dr. Sankirtana,
Yes, ma'am.
am I audible?
Yes, ma'am.
How did the use of antenatal steroids change for the late preterm babies in the recent years?
So,
What is the, in other words, what is the recommendation of antenatal steroids for the mother?
So steroids are recommended in less than 34 weeks when there is imminent delivery. And so mainly the studies have shown that there is a reduced mortality and reduced incidence of RDS, IVH, and NEC in the preterm babies.
What does the ACOG guidelines say? At what gestational age you can start giving antenatal steroids? I understand that it is given below 34 weeks, but at what gestation we start giving that?
When there is expected preterm delivery, ma'am, from 24 to 34 weeks.
Correct. So that is what I was trying to ask you. It is started at 24 weeks of gestational age and it is given to 33 plus 6 weeks of gestational age if there is an impending preterm labor in next 7 days. Do we give a second?
Sorry, ma'am.
Sankirtana, do
Yes,
we
ma'am.
ever give a second dose? When do we give a second dose?
If the course was completed more than 14 days, then they would recommend a repeat course, repeat single course to be given
What if
before.
what if the gestational age is 35 weeks at that point of time? Would you like to give?
No, ma'am.
If 40 days are over and it is 35 weeks now?
No, ma'am.
No, you
It's
cannot
steroids
give.
are not recommended
The
in late
gestation
preterm.
age should be less than 34 weeks only.
Okay.
Okay, go ahead. Okay, and one more question.
Yes.
So, in antenatal steroids, when we give betamethasone, do you know what are the salts which are used in betamethasone?
It comes in sodium phosphate salts in the injection form, and that is the other option other than dexamethasone to give 24 hours prior to the delivery in less than 34 weeks.
Betamethasone has both phosphate and acetate salts.
Yes.
Okay, so the phosphate salt in the betamethasone increases the duration of action of betamethasone. What does WHO recommend? Does it recommend betamethasone or dexamethasone?
Recommendation is dexamethasone because it's a essential drug and easily available and cheaper. But sometimes betamethasone is preferred because of this long-acting version with the phosphate salts, and only 2 doses can be given for that reason.
Okay. So why it is not given antenatal steroids is not given in late preterms?
The studies showed the benefits of steroids more in less than 34 weeks, and in late preterms, again, giving steroids can have the side effects of hypertension and
It has no
hyperglycemia.
benefit. It has no benefit with respect to RDS. Okay, you go ahead.
Yeah, Sankirtana.
Yes, ma'am.
Hello.
Yes, ma'am.
Yeah, Sankirtana. So just I want to clarify, betamethasone that is available in India is what you said is sodium phosphate, right? But what is the ideal salt is what Dr. Arpita told you, should be a mixture of acetate and phosphate, which is not available in India and in many LMICs, right? So as per the studies done, the benefits of dexamethasone and betamethasone are equivalent, and that's why WHO recommendation and our government of India recommendations say that dexamethasone can be given, right? So I want to ask you this question here. You have mentioned that magnesium sulfate was not given. So can you clarify whether this was an inborn baby or an outborn baby?
Outborn baby, ma'am.
Outborn. So if it was an inborn, would you have considered giving magnesium sulfate?
Less than 28 weeks, it's less than 32 weeks, it is recommended, ma'am. So in this
Yeah.
baby, we could have given the 24 hours prior.
So what is the indication for giving magnesium sulfate?
Imminent preterm delivery in less than 32 weeks.
Yeah, but if the delivery is imminent in the next 24 hours,
Next 24 hours.
okay, it can't be given for prolonged periods. Okay, yeah, continue.
Okay, Sankirtana, one more question.
Yes, ma'am.
What is triple I in chorioamnionitis?
It's another term used to describe it called intrauterine infection and inflammation.
Okay.
So labor and delivery details. Amniotic fluid was clean.
Told that there was no clinical chorioamnionitis. Would you like to clarify what is clinical chorioamnionitis? When do you label it?
So mother should have the criteria for clinical chorioamnionitis is presence of fever along with foul smelling liquor, fetal distress, increased total count, and uterine tenderness. Five criteria.
Yes, Sankirtana, the latest classification says that clinical chorioamnionitis is labeled when mother has fever and at least one of these signs and symptoms, which include tachycardia, leukocytosis, and pregnant with discharge, and this should be present along with amniotic fluid infection. So amniotic fluid infection is labeled when there is a placental pathology of infection, there is positive culture, or there is a biochemical evidence of infection in the form of low glucose. What the criteria which you told is just a suspected triple I. Okay, it is not a clinical chorioamnionitis. Okay,
Yes.
okay, go ahead.
So labor details, amniotic fluid was clear and there was reduced liquor. She was taken up for emergency LSCS in lieu of PPROM in labor, and baby delivered and cried immediately at birth on 27th April at 10:25 p.m. Cord milking was done. Baby had respiratory distress, so delivery room CPAP was started using TP's resuscitation. And Abgar was 7 at 1 minute and 8 at 5 minutes. An injection vitamin K was given. Coming to postnatal care, so in lieu of respiratory distress along with for preterm care, baby was started on delivery room CPAP and shifted to the ICU at our hospital. and baby required a maximum settings of 25% FiO2 and PEEP of 6 at 1 hour of life. And CPAP was continued till day 3 due to tachypnea. On day 4, a trial of CPAP was given, but baby had apnea and we had to reconnect to CPAP. So finally, baby was weaned off on day 6. Currently, baby is maintaining well in room air. The next issue was apnea. Baby had one episode of apnea on day 4. So the workup, including temperature, sugars, calcium, and septic workup were done. USG cranium was also normal. In view of apnea of prematurity, caffeine was loaded and continued with the maintenance dose. It was given till 34 weeks and stopped. Next issue was neonatal jaundice. Baby received phototherapy for 4 days in view of serum bilirubin being in phototherapy range. Coming to nutrition, baby was started on orogastric feeds initially at 20 ml per kg per day at 2 hours of life. Initially, it was donor milk and it was hiked every 12 hours at 30 ml per kg per day to reach full feeds by day 4. On day 9, baby had vomiting episodes. So, IV fluids was restarted and minimal feeds were given. Clinically, baby had no distension and septic workup was done, which was negative. X-ray abdomen was done to rule out NEC and that was normal. Baby required erythromycin and finally, baby tolerated full feeds from day 11 of life. Baby reached birth weight on day 17 of life. So currently, baby is on both OG and Pallada feeds, 14 ml OG and 15 ml Pallada feeds, second hourly, coming up to 180 ml per kg per day intake. So the calories are 115.
Okay, Sankirtana.
Yes, ma'am.
Wait, Sankirtana. Is there a particular or known or standardized definition of feed intolerance?
Not being able to reach feeds by day 7 of life, ma'am.
No, there is no standardized definition of feed intolerance. Okay, so it is like a conglomeration of many signs which lead us to the diagnosis of feed intolerance. There is no particular definition. So usually we say there is an increase in abdominal girth by more than 2 centimeters. If it has vomiting, there is gastric or if so if there is then 50% of the previous volume or more than 2 or 3 of them, it is feed intolerance. No,
Sorry, ma'am, it's not audible.
was I not audible?
Yeah, the voice is breaking.
Am I audible now?
Yes, ma'am.
Yeah. So there's no standard definition of feed intolerance. It is a conglomeration of several signs which lead to diagnosis of intolerance. Usually we say that the gastric are more than 50 the previous feed. Abdominal girth 2 centimeter. There is vomiting. There is abdominal tenderness or firmness. So all these signs and symptoms, more than 2 or 3 of them if present, then it is known as feed intolerance. There is no standard definition yet so far.
Okay.
You can go ahead, Kirtana.
Yeah. Baby is receiving calories of 115 kilocalories per kg per day and protein of 1.95 grams per kg per day. And baby is on supplements, multivitamin, tonoferon, and calcium. Baby had hypocalcemia on day 1. IV correction was given and repeat values were normal. On day 9, as I mentioned earlier, baby had multiple episodes of vomiting. So, in view of feed intolerance, septic workup was done and piptas and amikacin antibiotics were started. They were stopped after 3 days when blood culture was negative. ROP and osteopenia workup were yet to be done. KMC was initiated on day 8 of life. To summarize, baby of M, primary mother with hypothyroidism on thyroxine, growth scan was normal. She underwent emergency LSCS in view of PPROM at 31 weeks plus 3 days gestation with partial antenatal steroids cover. Baby had respiratory distress syndrome, apnea of prematurity, neonatal jaundice, feed intolerance due to GERD, and hypocalcemia. Currently, baby is in NICU for preterm care and also for observation of caffeine. Coming to examination, baby of M is a growing preterm. Environment, baby is in a radiant warmer with the set temperature of 36.5 degrees Celsius and measured temperature is 36.6 Celsius and heater output is 0%. Baby has socks, mittens, and cap, and is covered in 2 layers and is in nest. Coming to posture, baby is in supine position with upper limbs flexion is present and lower limbs some flexion present. And here we have the picture of baby in the nest placed in the warmer for reference. So baby is in room air.
Sankirtana,
Yes, ma'am.
what kind of nesting we are using in our unit? What is this type of nesting called? What are the types of nesting?
Full nest or half nest, depending on the to facilitate all the connections and groups in case baby is connected to ventilation.
I am asking you what is the no, I am asking you what is the type of nesting what is shown in this picture?
Oval nest. Ma'am.
It is a O type of nesting. Okay. So what is the other type of nesting what we use in several other units?
Sorry, ma'am.
This is an O type of nesting. What is the other type of nesting what we use in several other units, which is usually? Are you able to hear Sankirtana?
Yes, ma'am. You mean the nest like oval shape or a U-shaped nest, ma'am?
Yeah. So there is an O type of nesting which you can see in this figure, and there is another type of nesting which is used, which is a U type of nesting. Okay. This nesting is O type of nesting.
So babies in room air, nasogastric tube 6 French is used and fixed at 18 centimeters. Pulse oximeter and temperature probes are attached to the baby. Pulse oximeter shows saturation of 96% connected on the left hand and the range is 89 to 96% and heart rate is 128 ranging 100 to 160. There was no episode of desaturation or bradycardia during the examination. Coming to the vitals, as I mentioned, baby's temperature is 36.6 Celsius, heart rate 128, good volume and regular rhythm, and respiratory rate was 48 per minute, abdominothoracic in nature, capillary refilling time was less than 3 seconds, blood pressure was 68 by 42, mean of 51, falls between 10th to 50th centile for the gestational age and saturation was 96% in room air. Anthropometry, baby's birth weight was 1.96 kg and current weight is 2 kgs, falls between 10th to 50th centile, so it's in the normal limits. OFC is 29.5 centimeters at birth and currently 30 centimeters. Length is 43 centimeters at birth and currently 44 centimeters, all within 10th to 50th centiles in the normal limits. So in our unit, OFC and length are monitored weekly and weight is monitored daily. So for the reference, we are monitoring using the Fenton's preterm growth charts. So I have plotted the birth and current weight, head circumference and length here. General examination. Anterior fontanelle was 3 into 2 centimeters. It was at level and pulsatile in nature. Posterior fontanelle was not palpable. Sutures are open. Skull size and shape appear normal. Eyes and ears are normal. Oral cavity, there was no cleft lip or palate. There is no facial dysmorphism. Skin appears pink. There is no pallor or icterus. Good hydration and normal texture seen. Umbilicus, the cord stump has fallen off and umbilicus appears healthy. Genitals, male genitalia, no hernia, and anal patency is present. Back and spine are normal, and extremities are normal, no developmental dysplasia of hip. Coming to systemic examination, respiratory system, baby was comfortable in room air with no distress, no retractions. Air entry was equal on both sides. Cardiovascular system, baby appears pink, heart rate was 128 beats per minute, peripheral pulses were felt and regular with normal volume, bilateral femoral pulses were palpable, capillary filling time was less than 3 seconds, peripheries were warm, BP checked in the right upper limb was 68 by 42 with a mean of 51 and no visible precordial impulse seen. And heart sounds in all the 4 areas, S1 and S2 were heard, no murmurs noted. Abdomen was soft, umbilicus was healthy, there was no organomegaly and bowel sounds were heard. Coming to CNS examination, state of alertness, baby was in a quiet alert state with good state to state variability during the examination, and cry was normal and consolable. Movement of all 4 limbs was present.
Sankirtana,
Yes, ma'am.
what are the states of wakefulness and alertness?
There is 6 different states. Deep sleep, active sleep, drowsiness, quiet alert, active alert, and crying.
So when we should be doing the procedures and activities and everything for the baby, at which state of wakefulness?
So they should never, baby should never be interrupted during sleep, and the activity should be scheduled during awake states. And especially examination, ideal time to do would be a quiet awake state, as that would be convenient for the examination as well. And yes, that's ideal state.
Okay. Okay, go ahead.
Coming to cranial nerves examination, baby had visual fixation and pupillary reaction to light. There was no ptosis or nystagmus. Doll's eye movement was present. Rooting reflex was present. Facial symmetry was normal. Glabellar tap was positive. And baby had a response with blink and increased alertness, along with change in breathing and heart rate patterns to sound stimuli, and there was no nasal regurgitation and tongue symmetry was normal. motor examination. Bilateral symmetry was noted. Range of motion was normal in all the limbs. There were no abnormal movements noted during the examination. And passive tone, popliteal angle was 120 degrees, adductor angle 90 degrees, dorsal flexion angle 60 degrees, and scarf sign crosses the midline. And the active tone, arm recoil was present.
So, Sankirtana, what is your interpretation of the passive tone measurements that you have?
So, check for the appropriate normal tone for the gestational age, ma'am. And
You said baby is a 34 weeker, right?
yes, ma'am.
Okay. So normally the muscle tone development, how does it progress in what direction
From
in preterm babies?
cephalocaudal, so more tone and flexion will be seen first in the upper limbs.
It's opposite. So 28 to 40 weeks, it is chordocephalic, the tone development. Okay, and after the term gestation, it becomes reverse of that. That's how the babies start attaining milestones. You know, so 20 to 40 weeks, it is chordocephalic. So you'll have to go and probably recheck your angles because they are more actually. You know, they are the flexure tone. I mean, the tone is hypotonic because you're saying scarf sign is crossing midline, popliteal angle is 120 degrees, right? So you need to go and cross check your angles once. So remember, 20 to 40 weeks, it is chordocephalic.
Yes.
Yeah.
Reflexes, Moro's reflex was incomplete, and palmar and plantar grasp were present. Rooting and sucking reflex were present.
So why are you saying Moro's is incomplete?
So the components where first there is abduction and extension followed by the anterior flexion, ma'am. Baby does not have the adequate anterior flexion, which develops later than baby
So
34 weeks.
so when does Moro's appear and when is it complete? By what gestation?
From 28 weeks, it starts to appear, but all the components will not be present at that time. I think complete Moros can be elicited from 37 weeks.
So Moro's will appear by 32 weeks, and maybe as you said, it's only the abduction component that is there in the preterm babies. Like your baby is a 34 weeker right now, so only the abduction component will be seen, and you can get the adduction component and the complete Moro's only beyond 36 weeks. Okay. So that's so that you'll have to elaborate when you say Moro's incomplete. You have to tell what is seen and what is not seen here. Yeah, proceed.
This is the developmental supportive care checklist.
Sanketana, sorry to interrupt you. What are the primitive reflexes you can get in this baby right now?
Uh,
What is the first primitive? What is the first primitive reflex, and when does it appear?
blinking and startle reflexes.
Is it blinking and startle, or startle followed by blinking, or startle following the blinking?
First blinking reflex appears at
When
20,
does it appear?
26.
Okay, then
Next will be the startle reflex.
okay. When does it appear? You keep telling when does it appear.
Startle reflex at 28 weeks. And next, you see the pupillary reflex by 31 weeks.
It is pupillary reflex starts at 29 weeks. 29 to 31, you can get pupillary reflex. And then comes suck and swallow. Okay. Okay, go ahead.
So to just list the developmental supportive care checklist here. Coming to skincare, hydrocolloid dressing base should be used for attaching any adhesive tapes for skincare. And for massaging, coconut oil is used twice a day once the central lines are removed. And regarding feeding, the environment should be well supported with dimming light and reducing noises and any distractions that may be present. And also, swaddling during feeding will be effective for baby. And oromotor stimulation should be done regularly to facilitate better feeding and positioning of the baby. So, to reflect the intrauterine environment that baby had at the preterm delivery, the head and body should be aligned, and it should be in neutral position and slightly flexed forward. Shoulders should be rounded forward towards midline. Hands should be touching the face, and pelvis aligned and softly flexed, along with the knees, ankles, and feet, all of them aligned in a straight line, and baby can be kept swaddled and in a nest. Coming to the sound, there should be minimal sounds. So the healthcare staff in the NICU should talk softly near the baby's warmer. Any discussion should be away from bedside, and volumes of any telephones or mobiles should be reduced, and any alarms also should be set at a lower volume. And light should be dimmed except while during doing procedures, and there should be a cyclical system of day and night for dimming the light, so this will reflect the circadian rhythm. And during procedures, if there is a direct light at the infant, the eyes should be protected from the direct light. And we should also enhance protected sleep. So all the daily activities and routines that are done should be clustered together when infant is awake, in the awake state of. And dimming light also helps in safe sleep. Next is pain prevention and managing. So the non-pharmacological measures like swaddling, containment, non-nutritive sucking, breastfeeding, and oral dextrose or sucrose solutions are used. And the last one is family-centered care and parent support. So this also includes mainly kangaroo mother care of 6 to 8 hours per day.
So, Sankirtana, in the checklist here, you have listed 10 points. Can you tell what are the 7 core components of DAC? Which are of these? Which are the 7 core components, or how do you regroup them into 7 core components?
Uh, Activities of daily living, ma'am, like dressing, diaper change, massage, and all of these things. Um,
So that is one core component which comes as part of positioning and handling,
yes.
right? So which are the other 6 components?
Healing and stimulating environment,
Yes.
which will include the light and sound
Mm.
optimization.
Yeah.
Uh, Next is protected sleep. So the clustering of activities and not interrupting baby during sleep.
Correct.
And pain prevention and managing stress.
Mm.
So for that, regularly 4 to 6 hourly baby should be assessed, and if any procedures are there, pre and post procedure assessment should be done. And family centered care where parents are involved in decision making, and they're allowed in the NICU 24 hours, and they're involved in the daily activities and feeding
Yeah,
along with KMC.
correct. Then another two.
Follow up.
So optimum nutrition is another one, and care of the skin is another component. So this you'll have to regroup and know the seven core components. So if you are doing rounds in the NICU, right? So are there any cues that you know of that exhibit stress in the preemies?
Any change in heart rate, respiratory rate, abnormal breathing patterns, or baby's positioning and limb movements. Um,
You're correct. So one is autonomic disturbances, what you mentioned that you can pick up, or the motor disturbances you can pick up. What do you see? How will the babies react? Have you seen arching of the babies?
yes.
Having excessive movements, or how they keep their limbs in extension, or with the foot or the finger splaying can be there, right? So by all these you can pick up the cues of stress. Also during rounds, have you seen some self-regulating behaviors in the newborns?
So babies' hands touching their face or foot grabbing or holding onto their NG tube or hand in their mouth. Any of these, some of these will be the self-regulating responses.
Yeah. So the what your DSC does, what is the goal of your DSC?
This promotes better weight gain, better with with the morbidities also, less fluctuations with the heart rate, respiration,
Better tone development,
weight
better
gain.
neurological outcomes. Okay, you can go on to the next slide.
Okay, Sankirtan, I have few questions.
Yes, ma'am.
Can you provide any evidence in support of cyclical light? What you use in your unit? What are
Right.
the benefits of cyclical light on with respect to developmental supportive care?
So cyclical light is changed every 12 hours in the unit with the bright light and the dimming. Um, so this is part of the developmental supportive care because preterm babies don't are more sensitive and
No, can you provide a latest evidence, any Cochrane review with respect to impact of cyclical light?
it also facilitates the day-night circadian rhythm and which is better for the overall growth and neurological development of the baby.
That is the principle of cyclical light. Okay, so there are various kinds of lights which are used. So there was an Cochrane systemic review which was published in 2016. So it said that when cyclical light is compared with near dark light, or when cyclical light is compared with continuous bright light, in both these cases we saw that cyclical light has an impact in reducing the duration of the stay of the baby in NICU, and that those results were statistically significant. So the principle behind the cyclical light is definitely the effect on circadian rhythm, but the evidence in support of use is that it reduces the duration of the stay. Also, you have mentioned the cluster care, which you correctly said that it is given in the active state of the baby. Uh, so there is an evidence which supports that cluster care, it increases the sleep duration. That is why it helps in the developmental supportive care. It is a component of that. Also, the pain scores are reduced drastically. It also improves the heart rate, respiratory rate, the breathing pattern. And in long term, when you see the cluster care, when it is given, it impacts the height, weight, and head circumference. So it is better in the babies to receive the cluster care. Okay. Am I audible?
Yes.
Also, I would like to know what pain scale are you using in our unit?
We are using the premature infant pain profile, the PIPP revised tool.
Okay. So what are the components? Usually pain scales, what are the components?
All the pain scales usually include two components, ma'am. The behavior and behavioral with the babies that we notice on the baby, and physiological.
Okay. So in the scale what we are using in NICU, what are the behavioral components?
It has four components, including the alert state of the baby or the level of alertness, and others are in the facial expression with pro bulge and eyes, eyes squeezing, and the nasal flaring.
And from what gestational age we can use this pain scale?
PIP can be used up to 28 weeks till term for 40 weeks.
26 till term. Can you name some other pain scales as well?
Uh, Other pain scale we can use in preterm babies, N pass,
What
or
is the benefit of NPAS over other scales?
it can be used in preterm babies as well.
No, it has a benefit in sedation, assessing the sedation as well, apart from the pain relief. Okay. Next, why is oral sucrose never, is there any evidence which you can provide because of which oral sucrose is not used as a conservative management for pain control below 32 weeks gestational age? Do you know why is it not used?
I'm not sure.
Okay. So there was an RCT systemic review which was published in 2016, which considered 8 RCTs. And in one trial, they found that when oral sucrose was used for procedural pain, if they used oral sucrose for more than 10 times within 24 hours, it affected the neurodevelopment of the baby very drastically. Although it was a recent neurodevelopment, they did not assess the long-term neurodevelopment, but still oral sucrose, if you look into it in our unit also, we don't use oral sucrose below 32 weeks. We don't use sucrose at all actually. Okay, and is there any evidence of nesting and how does it support the development?
Nesting helps with aligning baby with respect to head, shoulders, pelvis, and lower limbs, aligned in the center, and also helps with the flexion of the upper and lower limbs. So this will reflect more of the intrauterine posture of the.
Can you quote any trial which shows any statistically significant impact on the physiological parameters by nesting?
Uh, Comparing nesting versus without any nesting, There was one study which stated that better heart rate and I'm not sure of all the parameters
Okay,
now.
so the impact of nesting, yeah, so nesting when compared with non-nesting in premature babies, it was an RCT which was published in 2018 in premature infants. It showed that it increased significantly the duration of active sleep and quiet sleep. It reduced the heart rate significantly, and the heart rates were stable over the course of hospital stay and duration of the study. And the mean body temperature was also increased in all the states of sleep. Okay, so this way the nesting supports in the developmental care, developmentally supportive care. Heart rate is impacted, sleep and quiet sleep, active sleep, quiet sleep, both are increased. Okay, go ahead.
So I just added a few pictures of our baby in the ICU. With the first one shows the nesting and the swaddling, and the second picture corresponds to the KMC.
So, Sankirtana, can you explain these terminologies? Zero separation at birth, IKMC, extended KMC.
Zero separation at birth is as soon as the baby is born, immediate skin to skin contact is given, and rest of the steps of resuscitation, cord clamping, and rest of the things are done while baby rests on mother's chest. And mother and baby are shifted with the skin to skin contact and continued postnatal care.
What is IKMC? And are you aware of any recent study that was published by WHO on IKMC?
No, ma'am.
So immediate the continuous KMC was is what IKMC means, and basically this was a WHO study in which the preterm babies were randomized to the intervention group, that is which received IKMC, and the other group which didn't receive. So the outcomes studied were death within 72 hours and within 28 days. And IKMC group had lesser mortality in both these outcomes, and this study was therefore stopped early because the outcomes were better in the IKMC group. I asked you what is extended KMC. What do you mean by extended KMC? Because you've mentioned how many hours of KMC is done in your unit, right? What is the average duration of KMC in your unit?
6 to 8 hours.
6 to 8 hours. What is extended KMC?
Extended KMC would be longer periods where apart from diaper change, baby will be continued in KMC. Even feeding and feeding is also given with KMC.
Beyond minimum 4 hours. Beyond 4 hours, if it is given, it is extended KMC. So that's what you're practicing, right? So here you have shown a baby who is properly nested and who is, properly restricted with the wrapping. So do you know of any assessment tool for the position, like how you have pains scoring scales and other scales? So position, how do you assess position of babies? Is there any tool available?
The head, neck, shoulder, pelvis, knee, and ankle joints all should be aligned.
So
And
any assessment tool are you aware of? Any scoring system to assess the position of preterms? Yeah, somebody answered it in the chat. So it is the infant position assessment tool, iPad tool. Okay. So whatever components you're telling, right? Head, neck, shoulders. So these 6 components up to the lower limbs, all the components are assessed. scoring 0, 1, 2. So you have a maximum score of 12. So ideally, the score should be between 10 to 12. So if you're scoring less, then your positioning is not ideal, and you need to improve the positioning. Okay, you can go on to your next slide.
This just shows the cyclical light that we're following, and during daytime and the night, dimmed lights. I've just included the neonatal pain assessment tools, and as I mentioned earlier, premature infant pain profile revised tool is the one that is being used, which is used from 26 weeks to term. And the physiologic components will be heart rate and oxygen saturation, and behavioral components will be alertness, brow bulge, eye squeeze, and nasolabial flow. So this is used during procedural and post-operative pains can be assessed, and it can be adjusted for prematurity as well. Some of the other pain assessment tools, price, neonatal pain, infant pain scale, comfort, neonatal facial coding system, NPAS, and Eden and Bernese pain scale for infants. My final diagnosis: baby of M, primary mother with hypothyroidism on thyroxine, growth scan is normal, underwent emergency LCS in view of PPROM at 31 weeks plus 3 days gestation with partial steroid cover. Baby had respiratory distress, apnea of prematurity, neonatal jaundice, feed intolerance due to GERD, and hypocalcemia. And baby is in ICU for continued preterm care and off capping for observation. And neurological examination was normal. Coming to the preparation of high risk discharge in less than 32 weeks babies. So these are the things that are taught to the parents to prepare for the high risk babies. So warmth maintained with covered with 3 layered clothing and oil massage twice a day. And they also taught the temperature touch method before feeding and thermometer assessment if baby feels cold. And in regards to feeding, to give measured pallida feeds until baby attains 1.8 kg. And first, the pallida feed should be given, followed by breastfeeds.
Sankirtana, why first pallida followed by breastfeed?
Um, babies, if with the full breastfeeds with sucking, if babies are still preterm, they lose weight or the adequate weight gain may not be enough because babies will not be able to take sufficient foods.
But if the baby, you have already given a pallida feed and the baby is full, whatever measured volume you have given, will the baby suck on breast if you give after pallida? Did you understand my question? If the baby is full, will the baby breastfeed thereafter?
Uh, Non-nutritive sucking can at least be established, and this will
So till what age would you discharge a baby on a non-nutritive sucking alone?
no, ma'am. Ideally, baby should be able to take breastfeeds as well.
Yeah. So non-nutritive sucking, you begin along with your KMC to teach the baby the suck swallow and then the suck swallow breathing coordination, right? But when you are discharging the baby will be on breastfeeds and measured feed for the adequate weight gain, because we can't quantify the breast milk volume, right?
Yes, ma'am.
And a baby will root only when baby is hungry. If the baby is full, the baby will not attach to the breast. So I feel the baby should be breastfed initially for at least 10 minutes. But since we can't quantify, the rest of the measured feed by either whatever palada, cup and spoon, or cup feeding that you're doing, that can be given. Okay, because you're not discharging the baby on NNS.
Yes.
Yeah.
The next component regarding infection, hand hygiene is taught to the parents and advised not more than 3 people to handle the baby. Cocoon vaccination is advised along with avoiding contact with the baby if any family members are sick. KMC to be continued after discharge also 6 to 8 hours minimum. And all the parents are taught bag and mask skills to parents as they still have high risk for angina. And to follow up for vision assessment, for ROP, hearing assessment, and language and motor developmental assessments. So the tests to be included before discharge for these preterm high-risk babies is a complete neurological examination and blood tests, PCV, and workup for osteopenia, phosphorus and immunity, TSH, and newborn screening when the baby is above 34 weeks, and hearing assessment with OAE and USG training.
So this your baby is a 31 weeker and currently you said 34 weeks. So for your baby, what would be the neurosonogram schedule since admission?
Initially at day 3 and day 7, ma'am. And
Mhm.
on follow up, it should be repeated at 40 weeks corrected age.
At 40 weeks, you want to screen for what do you want to see? So you said you want to do one between day 3 to 7. So 32 weeks. So day 7, yeah, fine, that's okay. Then would you do one prior to discharge?
Yes, ma'am. Before discharge also, ultrasound cleaning should be done, or at 14 and 28 days.
So one prior to discharge, and then you would do one at term corrected age, right? 40 weeks. So what do you want to see is what I'm asking. So earlier you're screening for IVH, right? When you're doing it early, and then prior to discharge you're seeing for something, and in the post discharge at corrected gestation of 40 weeks you're doing the neurosonogram again to screen for that. What is that? So it's many are answering rightly in the chat box. It's periventricular leukomalacia. Sankirtana?
Yes, ma'am.
Yeah. So you're screening for periventricular leukomalacia.
Okay, ma'am.
Okay. Yeah. Next slide.
On follow up, these babies will be followed up in a neurodevelopmental clinic, and here in our hospital on Fridays it is scheduled. And so they are followed up at 1, 2, 3, 6, 9, and 12 months. After that, they are followed up every 6 months till 5 years of age.
So for this baby of yours now, which is 34 weeks, with the weight of 2 kg, you said, and currently on partial pallada and orogastric feeds, right? So what is the discharge criteria of your unit?
Baby should be on full enteral feeds with pallada and direct breastfeeds.
Mhm.
We should be maintaining uh, temperature stability and hemodynamically stable.
Mhm.
Baby should have crossed birth weight and gaining weight in 3 consecutive days,
Okay.
and off caffeine for 5 days, 7 7 days without apnea.
Okay, so then your baby is gone. So this baby is 34 weeks now, was 31 weeks at birth. So when do you expect this baby to be on full enteral feeds?
By
So
34 weeks, ideally, babies can reach full enteral feeds, ma'am. This baby had feed intolerance in between where we slowed down the
mhm.
progression again.
So in other words, how you're going to assess this baby's maturity for the oral feeding, complete oral feeding? How will you assess it? And in case you find it is inadequate for this baby, what intervention can you do to help this baby to achieve full enteral feeding?
First, baby should have the suck, swallow, and breathe coordination, uh, and to have the swallow and breathe coordination for spoon or pallida feeds. And
Mhm.
baby should not be losing weight after starting pallida feeds. And if baby is not taking well or not tolerating pallida feeds well, oromotor stimulation can be done to improve baby's tolerance.
Yeah. So one, you do the NNS, right? And the second thing is you can do the oromotor stimulation. So any particular tool you're aware of or which you practice in your unit?
Yes, ma'am. The premature premature infant oral motor intervention tool.
Yeah, correct. So you will have to implement that and help this baby achieve good transition to the complete enteral feeding, right? So say by 35 weeks, another week you achieve it, okay, and you have done your screenings and you discharge this baby. So in your discharge advice, when will you call this baby for follow up? Because here schedule for neurodevelopment you have written at a corrected gestation age of 1 month, but you're discharging a 35 weeker, say 2 kg 40 grams 60 grams or so. So when will you call this baby for follow up?
Right after discharge, we call the babies 2 to 3 days after to check on how the parents are adapting to taking care of a preterm baby. In respect to feeding, if there are any feeding issues that have to be addressed, and weight, if baby is gaining weight or not, and counseling regarding these things to the parents. And
So if
thereafter,
you
we can follow the schedule.
So obviously you have to advise them because ROP screenings also will be ongoing, right? So do you group them on the same day of your follow up, or they are on separate days?
For ROP, now,
Yeah,
ROPs here in our unit are done on one specific day. So usually Fridays they are done so that the neurodevelopmental clinic and the assessment
yeah. So it is
and
on the same day, right? So you
ROPs.
have discharged a 35 weeker. You said you want to call once early to assess the transition to home environment with respect to thermoregulation, feeding, growth is happening right or not, and thereafter you will be seeing to it that they come for the ROP screening. At the same time, growth monitoring can be done. So initially, maybe you'll have to call them weekly or once in 2 weeks, as per how the weight is improving. If weight improvement is well enough, then probably you'll make it once in 2 weeks along with the ROP screenings, right? Once that is done, then for your neurodevelopment assessment, you
Sorry, ma'am.
We lost her voice.
It's not audible.
We lost her voice. I think should have got a phone call. Let's wait for a minute. Ashwini madam.
Yes.
Sankirtana?
Yes, ma'am.
Yeah, you can go ahead. Is that your last slide?
Yes, ma'am. This is the last.
Okay, sorry, I got disconnected in between.
Thank you, Kirtana, for that full presentation. I know you're just 1 month old in the journey of neonatology. Still many more months to learn neonatology. I believe half of you who are listening for today's class must have entered the journey of neonatology 1 to 2 months back. So you would have surprised by many questions. So you're in the journey. Do not worry. So go back, read the questions, whatever our excellent experts have asked today. So as days goes on, you'll be able to answer most of it. So I would like to thank both our experts, Dr. Ashwini and Dr. Arpita, for engaging the audience for so long and asking evidence-based relevant questions in this clinical presentation.
Sankirtana, that was a good presentation. Knowing that you're just entered into neonatology fellowship, so it's well prepared, and all the best to you. And thank you, Dr. Abhishek, for this opportunity. It's always nice to connect with students and have a good clinical discussion.
Thank you, ma'am.
Sankirtana, you have put a lot of efforts in spite of doing night duties continuously. It was really a good effort from your side. And next time, I'm expecting you to present even in a better way.
Yes, ma'am. Thank you.
So if anybody wants to ask any question related to the case, we can take max 2 questions. Anybody wants to ask any question? I don't see anybody asking questions. I thank you, everybody. We'll join back again next week with the informative talk. Thank you, everybody. Good night.
Thank you, everyone. Good night.
Thank you, everyone.